Hello and welcome to my channel. We want to continue looking at the drugs that affect the muscles of the GI tract. And today we want to look at all of those drugs that are left for us to look at least per the curriculum as we are looking at it. Don't forget to subscribe to the channel and like the page. All right, so we're going to look at drugs, firstly, that decrease the motility of the GI tract, either directly through muscle stimulation, muscle depression or muscle slowing down, or through dryness, reducing of water. So these class of drugs are known as the antidiarrhea agent. Antidiarrhea agent. And we use them to relieve, and by that we mean either stop or slow down the symptoms of diarrhea. The symptoms of diarrhea. Three main examples or types of drugs are used for such purpose. The first group is the absorbent. And as their name indicates, these ones are going to soak up water from the stool. And when they do that, they make the stool hard. The stool becoming hard slows down. This means it makes it difficult to move through the GI tract. That make bowel movement difficult. Sometimes absorbents are also used to remove toxins and bacteria from the GI tract. So, for example, activated charcoal has been used as a very good agent for removing toxins. Here are some examples of absorbents that we have: kaolin, pectin, activated charcoal, aluminum silicate, and pepto-bismol, bismuth subsalicylate. A second type of anti-diarrhea group or diarrhea agents are the anti-motility agents. Now, these ones are the ones that directly, through the nerves, the CNS system, slow down peristalsis by slowing down muscle movement. Smooth muscle movement. So the GI tract smooth muscles are slowed down, and the peristalsis process is also slowed down. Example includes opioids like codeine and morphine, and loperamide. And the final class of drugs, or final type of anti-diarrhea drugs, are the probiotics. These are used to replace bacteria. So they are called bacteria replacement agents. And the bacteria we are referring to are the so-called natural bacteria, natural good bacteria that are found in the GI tract. So these class of drugs are used to restore the normal bacteria found in the intestine. Example, Lactobacillus acidophilus or Saccharomyces boulardii. Now, the former is a bacteria, the latter is a yeast. Now, when it comes to anti-diarrhea, we want to look at some side effects. And typically, since we are slowing down peristalsis in the GI tract and drying the content of the stool, automatically we expect constipation to be one of our side effects. We also have nausea, vomiting, and sometimes abdominal discomfort or distension occurring. Another rare side effect that could occur, is the inflammation of the colon. Now, this is called the toxic megacolon. Toxic megalocolon. Now, this is where the colons become inflamed. And as our picture will show here, as our X-ray shows here, this is the colon and it has been inflamed, so swollen. And this is because the colon is dilating and receiving a lot of content. And this releases toxins, bacteria, and other poisonous stuff into the body. This is a rare condition, but it can occur. And once that occurs, you can have toxicity at the local level and toxicity systemic. Toxic megalocolon. Now, note also that there is no particular obstruction in the colon. There's nothing blocking the colon. It's just because it has been slowed down, it's now become too slow and is beginning to receive too much stool or content, and it is expanding or dilating and unfortunately inflamed. All right. Now, if we have to use our anti-diarrhea agent, we should also know that there are certain group of patients or certain conditions in which you want to be cautious with the use of these anti-diarrhea agents. The first is an acute abdominal condition where, just like when we were using laxative, because you don't really know the underlying cause or the reason, it's better to be cautious with the use of anti-diarrhea agents. Again, some form of poisonings. If you slow down the movement of the GI system, the bowel movement, you encourage absorption. And in a situation of poisoning, absorption into systemic circulation will be a very, very dangerous thing. So cautious use of anti-diarrhea in poisonous situations. If there is an obstruction in the GI tract, you also want to be cautious. Better yet, even avoid the use of these agents. And in the situation where you have a patient that's allergic to the agent, of course, you want to be cautious. Now, in diarrhea situations, our patients lose a lot of fluids and electrolytes. So most of the time when we are treating or managing diarrhea using anti-diarrhea agent, we want to replace these fluids and electrolytes. And ORS, oral rehydration salt, is one of the agents that are used. You can also use infusion, Ringer's lactate, or 541. But if a patient is going home, those ones have to be done in a hospital setting. But if your patient is going home, you want to help replace these electrolytes and fluids, ORS is our best bet. ORS contains the electrolytes, sodium, potassium, and chloride, and it also contains glucose to help your patient for two purposes, like we stated: prevent dehydration and replace their electrolytes. So that is the second class of drugs that affect the GI motility. The third class of drugs are antispasmodics, drugs that go against spasms. And what are spasms? Spasms are basically the involuntary movement of muscles. And in this case, because we are looking at the smooth muscles of the GI tract, we will say it is the involuntary movement of the smooth muscles of the GI tract. Now, movement of muscles, usually through the nerve system, is under the control of the neurotransmitter acetylcholine. Acetylcholine promotes the movement of muscles. It actually does it through its activity on receptors, two receptors, known receptors, nicotinic receptors, which are found at ganglion endings, and muscarinic receptors, which are found at other places, smooth muscles included. So in this situation, anticholinergic agents or antispasmodic agents are drugs that we are going to give to our patient that are going to go against the action of acetylcholine. In other words, they are going to block the activity of acetylcholine at the smooth muscle ending, nerve ending on the smooth muscles. In other words, at muscarinic receptors. Now, once they block the activity of acetylcholine, they prevent the impulses that are coming in from the brain to the muscles, which are causing the movement to be blocked, interrupted. And in preventing those impulses from reaching the muscles, there is the relief of the spasms. That's why we call them antispasmodic agents. Typical example is our drug Buscopan, hyoscine butyl bromide. We also have hyoscyamin, drutaverine, papaverine, and others. Side effects associated with these class of drugs include CNS effects like dizziness, drowsiness, weakness, blurred vision, dryness of eyes, dryness of mouth, etc., etc., and GI effects like constipation and nausea, sometimes abdominal bloatings. We should remember that cholinergic activity of acetylcholine, usually result in what has been called dumbbell, where increase in cholinergic activity results in diarrhea. So if we go against cholinergic activity, we will have constipation, and that is why our side effect is constipation. Now, dumbbell, which helps us remember the cholinergic effect, means one, the D is diarrhea or defecation. The U is urination. The M is meiosis or constriction of the pupil of the eye. The B is bradycardia, the slowness of heartbeat. Another B is bronchospasms, difficulty in breathing. E is emesis or promotion of vomiting. And it can also mean excitement of skeletal muscles. First L is lacrimation or tearing. The second L is lethargy or fatigue. And the final S is excessive salivation. So salivation, excessive drooling. Dumbbells. This is an acronym that has been developed to help us remember cholinergic effects. And so anytime we have anticholinergic activity, we have the opposite of dumbbells effect. All right. When we are using cholinergic or anticholinergic drugs, we need to be cautious in people who have toxic megacolon or megalocolon. We need to be cautious in patients who have ulcers because of the spasms. We need to be careful with patients who have some form of skeletal muscle disorder, high blood pressure, or ulcerative colitis. Now, the next class of drugs we want to look at that affect the GI tract system are the emetics. The emetics. Now, these are drugs that we use to induce or cause vomiting in our patients. Now, the activity, the way these class of drugs works is either they directly irritate the GI tract It's like you putting your hand into your throat and irritating your GI tract and causing yourself to vomit. So we have drugs that can directly irritate the GI tract. Or we can also work through the brain through the chemoreceptor trigger zones, where it is an indirect activity triggering these zones in the brain to cause vomiting or to induce vomiting. Examples of drugs that we use as emetic drugs include apomorphine, calpric sulfate, ipecac, and emetics. When we talk about emetic drugs, some side effects we expect include nausea, diarrhea, GI upsets, and remember we also said indirectly through the chemoreceptor trigger zones, those ones also give us CNS effects like CNS depressions, though mildly. And if we are using ipecac, large amounts being absorbed will result in cardiotoxicity. We encourage that to avoid the use of emetic drugs in patients who have ingested corrosive chemicals. Bringing those chemicals back to the GI tract can burn the GI tract. Those who have ingested petroleum products, we want to avoid inducing vomiting. Patients that are unconscious and patients that are convulsing. Convulsing and unconscious patient, if you induce vomiting or emesis, you probably will cause the content of the GI tract to move into various unexpected regions, like into the lungs, which will result in other complications. All right. Now, emesis are sometimes induced, for example, in drug overdose, where you have a patient who has overdosed on a drug, or sometimes in poisoning situations, we may induce emesis. But we are also saying that you should be cautious when you have to do it, especially if the thing or the chemical or the product injected is corrosive, petroleum, or your patient is unconscious or convulsing. That is emetic agents. Then the final class of drugs we want to look at are the antiemetic agents, drugs that go against emesis. These are drugs that are effective against vomiting and nausea, and like their counterpart emetic drugs, they can also work locally, directly through soothing the GI tract, or centrally through the chemoreceptor zones. When it comes to antiemetic drugs, we have various classes or various examples, and we'll look at a few of these. So the first group are those that are known as the dopamine antagonist or dopamine receptor antagonism. Antagonists. These are drugs that are going to block activity of dopamine on dopamine receptors. We are told they do that on dopamine 2 receptors in the CNS. And these receptors, particularly the ones that are found in the chemoreceptor trigger zones, by blocking the activity of dopamine at these D2 receptors, they reduce the urge to vomit, thus helping stopping vomit. So example, metoclopramide. Phenothiazine antipsychotic agents also work as dopamine antagonists. Examples of these phenothiazine antipsychotics include chlorpromazine, prochlorperazine, flufenazine, promethazine. Now, I'm sure you have probably met promethazine. It comes in as an HCl, promethazine HCl, or promethazine thiochylate, also albumin, which is generic. Then we have the butyrophenols. The butyrophenols. So domperidone, haloperidol, droperidol. Domperidol being one of our most popular antiemetic agents. In fact, it's available as a suppository dummy, dummy 10, dummy 30, available for both adult and for children. The next class of agents that can help us as antiemetic agents include anticholinergic agents or drugs. So hyoscine, as we spoke about as an antispasmodic agent, can also help us as anticholinergic agents. Then antihistamines. Antihistamines which block the activity of histamine on histamine receptors. And here, mostly we are looking at histamine H1 receptors. So cyclizine, cenarizine, diphenhydramine, dimenhydrinate are all examples of antihistamines that we can use to help stop vomiting. Serotonin 5-HT3 receptor blockers, another class, normally utilized for chemotherapy-induced vomiting. Very effective for those. Examples of these 5-HT receptor blockers include ondansetron, ganacitron, tropicitron. And we are also told that ginger, our normal ginger, contains gingerol, which is also an agent that acts as a serotonin receptor blocker. This is also one reason why ginger has been used as an antiemetic since ancient times. Other agents that have been used as antiemetics include steroids like dexamethasone, neurokinin 1 antagonist like casopitant, and aprepitant, rolapitant. Then we also have benzodiazepines, anxiolytic agents like lorazepam, alprazolam that also helps us with antiemesis. So you can see that there are various diverse classes of drugs that are used as antiemetic agents. And depending on the type of emesis you are facing, you may have to make a choice among these. For example, a pregnant woman vomiting will most likely be given promethazine, thiochylate, or domperidone, metoclopramide. Whereas a chemotherapy-induced vomiting may be given ganacitron or ondansetron. So the point is, there are various options, and it depends on the prescriber and which they will go for based on their own clinical evaluation. Side effects of our antiemetics depend on the emetic class you are using and the effects that you expect. So, dopamine antagonist normally gives us dry mouth, constipation, fatigue, tinnitus, muscle spasms. Anticholinergic antihistamines will also give us constipation, drowsiness, dry mouth. 5-HT3 receptor blockers will give us constipation, dry mouth, fatigue. Neurokinin 1 antagonist will give dry mouth, heartburns, decreased urination. Now, I should say here that these are just a few that has been selected, but the side effects are really wide. But the point I want to bring your mind to is notice how dryness of mouth, constipation runs through all of them because of their activity normally at the chemoreceptor trigger zones. You want to avoid these antiemetics if you have a patient that is known to be allergic to the agents. You have a patient who is already severely depressed in the CNS, having CNS depression. You don't want to compound the depression by giving these agents, for these agents are depressants. And you want to also not use these agents in a patient with hepatic problems, with liver dysfunction, because these agents are metabolized by the liver. All right, so that concludes the other part of the agents that are used in the GI tract. I hope you have learned something. Have a wonderful, wonderful rest of the day. Please don't forget to subscribe to the channel and like the page. God bless.